Welcome to the Healthcare Unfiltered Express, where I conduct short video interviews packed with relevant and timely information that you cannot miss. So sit back and enjoy the show. Okay, it's Healthcare Unfiltered Express, and with me is Dr. Vincent Rajkumar from the Mayo Clinic. Vincent, welcome to the show.
Thank you so much, Chaddy.
And you've been on my other long-form Healthcare Unfiltered, but today I have you on because we really want to talk about something new, which is a recent ODAC ruling, particular to Blenrep, which is an agent that you're going to describe to us a little bit, and it's obviously was proposed to be approved for the treatment of patients with multiple myeloma. So first of all, tell us what Blenrep is, and let's talk about the decision of the ODAC not allowing this to move forward and your thoughts on that, and what's your opinion moving forward?
So anyway, thanks, Chaddy, so much for having me. And for those of you listening, this Healthcare Unfiltered Express that Dr. Naban's got, you will be able to see both of us on YouTube with the video in a few days, Chaddy?
Yeah, I would say by maybe late next week.
So the same thing will be there, but we thought we'll just open up spaces as well so that people can listen in as we talk about this, so we can get your feedback live on this whole belantamab story, as well as probably your idea for the Healthcare Unfiltered Express. We have had a huge number of drug approvals for multiple myeloma. We are very grateful to the regulators and to the pharma companies, patients, investigators. So 19 new drugs in 20 years. And a lot of drugs targeting BCMA, 2 CAR-Ts, 3 bispecifics. So it's in this crowded space that belantamab is seeking to enter. Okay, it is also targeting BCMA, but it's not a bispecific, it's not a CAR-T, it's an antibody drug conjugate that delivers more lethal weapon inside the cell. It was approved previously based on DREAM-1, DREAM-2 studies with accelerated approval a few years ago, and then withdrawn from the market. It is well known that although the drug by itself has significant single-agent myeloma activity, it also has significant eye toxicity. And the first confirmatory trial was negative, and as a result, the drug was withdrawn. 2 other randomized controlled trials have been subsequently published in the New England Journal of Medicine. These
DREAM-7 and DREAM-8.
The DREAM-7 and DREAM-8 studies. The DREAM-7 was head-to-head belantamab bortezomib dex versus daratumumab bortezomib dex. Almost 500 patients showed a PFS benefit and an overall survival benefit. And DREAM-8 had pomalidomide instead of bortezomib. Again, about 300 patients in that trial, and significant PFS benefit was seen. The same degree of eye toxicity, unfortunately, 80-90% of patients.
What are the eye toxicities, Vincent? Just like maybe in 30 seconds or less, what are these top 3 eye toxicities we're talking about?
We're talking about corneal problems. It's basically a corneal toxicity, which leads to pain, itching, blurred vision, and if you leave it unchecked, probably loss of vision. So it prevents people from, if you don't tackle it, you can have significant visual loss, not being able to read, and things
real.
like that.
It's a real thing.
It's a real thing. It's a real thing. And then because of the itching and the dryness, you need to put artificial tears,
right,
regularly. So it is a bothersome toxicity, and it's something that is not trivial. And because of that, you need to get an ophthalmologic exam before and then prior to pretty much every cycle, to make sure that it's safe to go on and continue the treatment.
So the DREAM-7 and DREAM-8, they did show overall survival benefit. And one of the things that were...
DREAM-7 did. DREAM-7 did. DREAM-8 is smaller study, so we don't have data fully on survival.
7. One of the things that shocked me, at least, a lot of times when you see that overall survival benefit, it's almost kind of like more of a slam dunk type of thing from ODAC. Tell me what your thoughts are on that decision and why do you think maybe, I guess, I presume you were a bit unhappy with the decision.
Not unhappy. I was just shocked because, we have a situation where a drug has shown in a head-to-head trial. Most of the time in phase 3 trials in myeloma, you're talking about a trial of 3 drugs versus 2 drugs and the triplet winning out. Here we were talking about 2 triplet versus triplet trials in which the experimental arm with belantamab had shown significant benefit. I mean, in the DREAM 7 study, the PFS difference was like almost 2 years longer median.
Right.
So it's not like a small benefit, and the overall survival benefit was also there. So in that context, the shock is that how come this was not enough for approval? But I think you have to step back and see, really go through what actually happened. Okay, and
Okay.
the 2 important points are, number one was that there was a concern, legitimate concern by the FDA, and then reflected in the ODAC vote, that we have no idea what the right dose for belantamab is, at least not from these 2 trials. There's lots of dose reductions. You couldn't possibly give it every 3 weeks, and that's not what anyone's going to be using it at. And so, like, do we even know the right dose to make sure that it's safe for patient care? That was one of the concerns.
Do we know if the toxicity, the ocular toxicity, dose dependent?
Yes, it is. It's
Okay.
definitely dose dependent. And so you could give this drug every 2 months, probably every 3 months, even probably every 4 months, and greatly minimize the eye toxicity. And there's data that you will preserve most of the benefit. So as clinicians who are aware of clinical practice, I mean, we had belantamab available commercially for a while, and it still was commercially available in the UK. I myself have referred patients to the UK for treatment. So we know that even a single dose can sometimes give you significant benefit. So because of that, we were quite confident that, once the drug's approved, we can still adjust the dosing frequency and greatly minimize the risk of eye toxicity.
Mhm.
And so, but that's not the question, right, for the ODAC. The question was like, do we know the right dose? And frankly, the answer is we don't.
Right.
At least not from these 2 trials. And the second question is not whether the FDA should approve the drug or not. The question was like, is the risk benefit okay, with the precise wording being at the type of dosage for the intended patient population, which is one prior treatment, when we have so many options. So I guess I am a little bit more sympathetic to the ODAC vote, that they answered the questions as they were phrased. And my hope is that, taking those answers into account, the question before the FDA is not the answers to those 2 questions. The question is, taking all of this information, should the drug be on the market or not?
Right.
And I hope that answer is yes, and that the drug is on the market. And then we have all kinds of labels, REMS programs, guidances for ophthalmologic evaluations. And then we as oncologists also make a good effort in terms of when to use, how to use. We're not going to just jump in and use it in one prior line. We're not going to jump in and use every 3 weeks.
When is that FDA decision expected to be?
I don't know. I think usually it is probably within 3 to 4 months of an ODAC. So I am still hopeful, because I feel like this will be a great drug to have for patients. And I can tell you in precisely which situations, in spite of all these 25 myeloma drugs, this drug is still important.
And just for folks who are listening live, I will be actually hosting Dr. Greg Nowakowski, who is also from the Mayo Clinic, and he will be on Healthcare Unfiltered Express very soon, discussing behind the scenes at ODAC, because he was at ODAC and he did have a vote. So for folks who are actually watching this, listening this, I think will be definitely an episode you should look at. Vincent, before I let you go, this was really important to put that in context. And what type of management to these ocular side effects have you done in the past? Like, if you have to advise somebody who is using it in the future or have used it, What can they do aside from artificial tears to minimize or mitigate these?
I think, I'm sure that the ophthalmologists know when to prescribe like steroid drops and artificial tears and how to use them much better than me. There were many patients who testified at ODAC in terms of, how they actually manage. By far, the most important thing is changing the dose and the dose frequency. That's really the key. It's like bortezomib. When it came out, twice a week, IV, most people were getting neuropathy. We do once a week subcutaneous, and then if there's any concern, we make it even once every 2 weeks or give 2 weeks break. So we figure out a way to use it, and lo and behold, now we can have patients taking even maintenance bortezomib for a long time. So I hope that works out. And I just want to say that there are many patients who cannot get bispecifics and CAR T. These are not utilized. I mean, CAR T is utilized in 10-15% of patients who are eligible for the procedure. And bispecifics are also not easy to give. They're approved for fifth line. So these are drugs that are not available in rural areas, in regular practices. It's not like giving daratumumab. So Blenrep, on the other hand, requires no T cell collection. It doesn't have the CRS, it doesn't have the neurotoxicity. I can just do one dose.
Right.
And not even redose till I'm sure that the eye is okay, even if it takes 2 months. And so it does provide access to BCMA-targeted therapy to a large number of patients quickly, and particularly if they have a high tumor burden, where the risk of CRS and neurotoxicity is very high with bispecifics and CAR T. This can reduce the tumor burden. Many of these patients, you say, give bridging therapy, but boy, they failed all the other drugs. So what bridging are we going to give? That's getting the tumor burden down. So this is a drug that can provide that benefit. And then the other thing is even frail patients. Sometimes patients are frail from the myeloma and you just need the disease control quickly. And you can switch. We can just go from Blenrep to something else once we know that it's safe to give a CAR T cell therapy or a bispecific because the tumor is now controlled.
Vincent, thank you so much. We will await the FDA decision. Appreciate giving us some thoughts on Blenrep. Dr. Vincent Rajkumar on Healthcare Unfiltered Express. Thank you so much.
Appreciate it.
Thank you for listening to this edition of the Healthcare Unfiltered Express. Until next time, take care.